now going to hand it back over to, I believe, Aiden, who's done an amazing job also organizing this session. So thank you very much, Aiden, for all your work for the symposium, but also for this specific session. Thanks.
Thanks so much, Dr. Oskadiz. Our podium presentations will be 5-minute presentations followed by 3 to 4 minutes for questions. After the live oral presentations, we'll post the links for the recorded presentations in the chat, and we'll make time to view those recorded presentations until 10:45. They can also be reached via the same link after the conference. Note, we are deviating from the program as Andy Wirko was not able to join us due to displacement by the war in Ukraine. We're keeping him and other refugees displaced in this and other conflicts in our thoughts. In light of Andy's inability to attend, we'll start with Gitstrava. Gitstrava Vigunta is a medical student at Rutgers, New Jersey Medical School. And feel free to post questions in the chat. Those can be addressed at the end of the 3 or 4 minutes we have for questions. Gitstrava, feel free to begin whenever you're ready.
Okay. Hi, everyone. My name is Geeta Shravya-Vegunta, and I'm a second-year student at Rutgers, New Jersey Medical School. Today, I'll be discussing our work on the pediatric research productivity of anesthesiologists in the West African College of Surgeons. Pediatric anesthesia is underrepresented in literature, especially in low and middle income countries and regions, such as West Africa. Analysis of existing research allows for the identification of research priorities, areas of potential collaboration, and research gaps. For some context, the West African College of Surgeons, or WACS, is the oldest and largest surgical training and accreditation body in the West African region and supports 17 countries. It includes traditional surgical disciplines, as well as radiology, dental surgery, and anesthesiology. To our knowledge, this is the first study analyzing pediatric anesthesia research performed by anesthesiologists in West Africa, specifically in WACS. This study aims to characterize pediatric anesthesia research, anesthesia publications by anesthesiologists in the West African College of Surgeons from 1969 to 2021. We performed the study by obtaining a roster of all WACS physicians and filtering it for anesthesiologists. We then queried Scopus for all the publications authored by each WACS anesthesiologist. We created a database of all the publications and logged information such as article content, author collaborations, study design, and research level for each publication. Finally, we filtered through all the articles to more closely analyze manuscripts focusing on pediatric anesthesia. From the WACS roster, we found 246 anesthesiologists, 153 of whom were published, with a total of 1,379 manuscripts. Of these manuscripts, 955 were unique across all disciplines. 658, or 69% of the unique articles, were about anesthesia. 88 of the anesthesia manuscripts, or 13%, were about pediatric anesthesia. When studying collaborations, we found that 72% of the studies were independent and did not involve cross-institutional collaboration. 23% involved collaboration with another African institution, and 6% involved collaboration with a high-income country. We found that articles written without collaboration had the widest breadth of anesthesia topics. However, something to note was that the earliest collaboration we found in the pediatric anesthesia manuscripts was in 2011, so it's possible that these proportions will change going forward. The most common study designs included case reports at 30%, prospective studies at 26%, and retrospective studies at 15%. Most articles, or 59%, were clinical in nature. 27% of the manuscripts focused on pediatric perioperative care and 16% on pharmacology. Only 2% of the articles studied pediatric critical care or pain management, and there were no articles about neuroanesthesia. The majority of the manuscripts reported outcomes at 48%, or morbidity and mortality at 34%. To summarize, we found that the minority, or 13%, of anesthesia articles published by WACS anesthesiologists were related to pediatric anesthesia. The majority of this research was independent and focused on outcomes-based clinical research. The most commonly studied pediatric content areas were perioperative care and pharmacology, with little work in critical care, pain management, and neuroanesthesia. This project focused on a subset of data from a larger study about anesthesia research by wax anesthesiologists. So we're interested in how the adult anesthesia research compares to pediatric productivity. We look forward to continuing to work with this data and to compare the pediatric anesthesia research output to other regions in Africa, other low and middle income regions and countries, and potentially to high income countries as well. And with that, thank you for listening, and I'd be happy to take any questions.
Thank you, Gita Srava. If we don't have any questions right away, people can feel free to post them in the chat later on. And also feel free to reach out to Gita Srava with additional questions. Since I don't see any questions coming in right away, I think that we can move on to our next research presentation. Next, we have Sid Zaidi, who's a research aide at Duke University School of Medicine. Sid, please begin whenever you're ready.
Hi, can you all see my screen? And just checking if everyone can hear me.
Yes, we can see and hear you.
Awesome. Well, thanks for having me. It was incredible to listen to all the people sharing their experiences and work today. I'm Sid. I'm a senior research aide at Department of Surgery at Duke University School of Medicine. And today I'll be presenting on behalf of my co-authors from Duke and Association for Socially Applicable Research in India on under 5 surgical outcomes. Pediatric surgery globally and in India is neglected in research policy and planning, as we have been discussing today. The lack of attention is alarming, considering that 1.2 billion children and adolescents in low and middle income countries lack access to timely, safe, and affordable surgical care. Limited workforce also impedes surgical access. For instance, India had about 1 pediatric surgeon per million people in the last decade, which is almost 14 times less than the US. With large pediatric population and high neonatal, infant, and under 5 mortality rates, India needs to urgently scale up its pediatric surgical care in the health research and policy agenda. Our ongoing scoping review has found negligible research on under 5 surgical rates. And till now, we have found just one study which talks about pediatric surgery and its estimation in India. Hence, we definitely need more research in this domain. The aim of this study was to estimate population level pediatric surgical incidence in under 5 age group using nationally representative sample. And we also wanted to look at differences across these outcomes along some socio-demographic dimensions such as sex, place of residence, and health sector where people receive treatment. This was a retrospective analysis of national sample survey, which included over 100,000 households and which was conducted in 2017-2018. Standard multi-level cluster sampling was used for generating national level estimates. We looked at 3 main outcomes for under 5 inpatient surgeries. Surgical rates per 100,000 children, percentage of surgeries in this age group relative to all inpatient admissions for the same age group, and then percentage of pediatric surgeries relative to surgeries across all the age groups. We found that nationally about 100,000 surgeries were performed among children under the age of 5 in 2017-18, making the surgical rate close to 253 surgeries per 100,000 kids. These pediatric surgeries form about 9% of the total pediatric hospitalizations in the same age group, but only about 2.5% of the inpatient surgeries across all ages. When we compared our estimate to the previous study estimate, we found that we were slightly above the estimate from the local cohort study. When looking at differences across different dimensions, we found that male children had over 3 times higher surgical rates than female children. Rural areas lagged behind urban areas significantly, and then the rate was higher in private health facilities than that in public facilities. These patterns are typical to India and which have also been observed across different population health outcomes and health system indicators. One important thing to note here while looking at this graphic is that the scales for the different groups are different here. But we also found similar patterns when we looked at other surgical incidence outcomes. So for instance, under 5 surgeries as proportions of under 5 hospitalizations also had similar patterns. The only place where this pattern kind of flips is when we look at the under 5 surgeries as proportion of surgeries across all age groups. And in that case, for rural areas, we see that rural areas do somewhat better than urban areas, although the margin is pretty small. We also used a simple linear model to look at the association between surgical rate and age. And we found that the surgical rate increased by about 205 surgeries for every 5-year jump. But we need to be careful while looking at these findings, especially as we move to the age groups which are towards the extremes. To our best knowledge, these are the first nationally representative estimates for under 5 surgical incidents in India, and we believe that they can provide insights for ensuring health equity in India's national planning. Our study also has multiple limitations as listed on the screen. The most important one being that since this was a household survey, there was no way of assessing the real need of surgeries among a pediatric population, which is in line with a lot of LMIC literature. So we believe that we need more research, especially in determining true surgical need and understanding factors which underlie low surgical uptake. Well, thank you so much for listening. You can reach out to me on my email or Twitter, and thanks once again for having me.
Thank you, Sid, for sharing that. Everyone feel free to reach out to Sid with any questions you may have. I just posted in the chat a link to the recorded presentations that represent the rest of the presentations and abstracts that people have submitted for the conference.